This meeting is being recorded for the first half. We have a couple of exciting topics to discuss today. We have an external speaker, Arash Shaban-Nejad. He's from University of Tennessee, and he's going to be talking about the precision population health to support COVID-19 pandemic preparedness, response, and management. And we have a manuscript abstract presentation from our N3C publications committee on outcomes of COVID-19 in cancer patients. And Noha Sharafeldin, she's on as well to be presenting that. Just on a very high level, this dashboard you guys are familiar with, we have currently 88 sites that have executed DTAs, 42 sites have deposited the data, and 208 sites that have DUAs, data use agreements, that have been executed, and 56 sites that have released the data in N3C enclave. Arash, I'm going to actually, if you want to present your screen, I can stop presenting, or I'm happy to bring up your slides as well, whatever you feel like.
Show it. Can you let me share?
Sure.
Okay, thank you.
Thank you so much.
Okay.
Do you need share permissions? Is that not showing up for you?
Well, let me see. I think I can share now. Can everyone see the screen?
Yes.
Okay. Let me know when I can start.
Go ahead.
Okay. Thank you very much for having me. My name is Arash Shaban-Nejad. I'm an assistant professor at the Center for Biomedical Informatics at the University of Tennessee Health Science Center in Memphis. And so I'm sharing some of our experiences in designing tools to support COVID-19 pandemic preparedness, response, and management, but more broadly in the context of urban health surveillance in Memphis. I talked a little bit about the problem, and then I'm going to talk about the specific method and framework we are using, and I will then show you a couple of systems we have developed, and also our work on progress on implementing what we call it Urban Health Observatory, or UFO.
Hey, Arash, sorry to interrupt. I think the way you're presenting, we're seeing the slide that you're presenting and the next slide that's coming up.
Okay, let me.
So maybe you have to go in presentation mode.
Oh, it has something to. Okay. Better.
Yep, perfect. Yep.
Okay.
Thank you.
You're welcome. Thank you. Okay, so the problem is COVID-19. I'm not going to go to the burden of COVID. Probably everybody knows what's happening, and also the problem is disparities. So COVID-19 is not impacting all population equally. So disparity in COVID-19 can be seen in disparities in illness, in hospitalization, death, testing, and vaccination. And so you have seen all sorts of articles talking about this kind of like social determinant of health related to COVID-19 and what's happening among people with lower social economic status. And also we have seen articles coming up about disparities on vaccine distribution and uptake. And so again, we can talk about the causes of causes or systemic health and social inequalities in the US. So according to CDC, we have a certain class of social determinant of health. So we try to redefine some of these classes according to indicator we could extract, linking to and link them to the COVID-19 surveillance. So broadly, we classified these indicators into 6 broad categories: economic stability, education, health and healthcare access, neighborhood and built environment, social and community context. And then, I think that many of people are familiar with the concept of precision medicine and precision health. So we actually focusing on the concept of precision public and population health specifically here. And we believe in order to address precision population health, we need to incorporate a wide area of different data set addressing precision observation assessment, precision health promotion, precision population engagement, early detection of disease, precision prevention, treatment, and last but not least, precision equity. Usually addressing each and every category mentioned here, we need a very complex multifactorial web of causality, and so these are not trivial. So using what we usually need to perform some sort of what we call it knowledge-based modeling to link heterogeneous data set to each other. And in this category, we're going to fall into a lot of traps linking to confounding biases, and also the lack for health effects on some of this downstream outcomes. And so we need to deal with a lot of different sort of data sets. So many of these data sets are easy to link to individual, some are a little bit trickier to link to individuals, and some of these data sets exist only at the population and aggregate level. And so the main challenges we're dealing with is, like, first of all, we need to deal with distributed heterogeneous data sources, which are usually collected at a very poor temporal and geographical resolution. And many of them may not be even representative of the population of interest. So we came up with a framework based on evidence-based public health, and we collected 3 types of knowledge. Type 1 knowledge usually collects data on the causal links, like A causes B, mosquito bite causes malaria. And the type 2 knowledge usually talks about the intervention effectiveness, looking at the existing intervention and explore the effectiveness of this interventions. And type 3 knowledge, which is I think very important, is like using all the knowledge at type 1 and type 2 and coming up with new intervention to respond to specific, for example, health problem. So we call it type 3 knowledge. So we collected several data sets from existing data sources at the regional and local level, including Memphis neighborhood quality data. We collected this data set using some of our third-party collaborators at Memphis. We have information for Right now, 128,000 single residential units in Memphis, and for each property, we have close to 200 attributes attached, talking about number of broken windows, the tax delinquency, the garbage collection period, and then all sorts of very granular data set tells us a lot about social economic status of people living in those neighborhoods. And also we collected data from CDC 500 cities, which are data set at the census tract level. And we extracted data on other socioeconomic status from American Community Survey, Nielsen Consumer Data Set, Policy Map, and US Census. And specifically, we use also ESRI for information about crime data. And we collected the type 2 knowledge on intervention effectiveness from CDC database of intervention, focusing on the socioeconomic factors. And also we have performed first-hand analysis in Memphis, looking at different socioeconomic indicators, so we call them sociomarkers versus biomarkers, to find out the link between those sociomarkers with some adverse health outcomes. So in one of our articles, for example, we published, we looked into the role of sociomarkers in predicting asthma patient at risk of hospital visits, pediatric asthma patient. And so looking at biomarkers, we could come up with 65% of accuracy for prediction. And then combining sociomarkers with biomarkers, we improved the quality of prediction by 1%, 66%. But what was striking was like the third model. So we ignored all information about the biomarkers. We don't know anything about the severity of disease. We don't know anything about patient, for example, underlying health condition. But looking at the neighborhood quality of patient residents, so we could accurately predict the chance of a hospital admission by 61%. And also we did other types of analysis. We find, again, strong link between socioeconomic status with development of pediatric asthma, or we found geocluster comorbidity pattern are more dense in lower socioeconomic neighborhoods. And so this is what you got, for example, in Memphis. Somebody else might get a different result based on the density of population, the neighborhood properties in other, for example, regions or cities. And probably might assume the result one might get in Manhattan might be different. For example, a zip code in New York is more multicultural, and people usually are not easily classifiable under one category. So we also work with University of Tennessee Health Science Center COVID-19 registry to get information about testing. And so we also follow the testing practices to time. And we used what we call it explainable AI, the combination of semantic web and explainable AI model to actually create a recommender system that uses all this integrated data set at the individual level and group level, and to an analytics engine can generate recommendation for policymaker linking, for example, social economic status and neighborhood quality, and making decision about, for example, intervention, for example, about school reopening. So the framework actually consists of 4 steps. So we integrate a large volume of data set, and then we perform a statistical and qualitative analysis. Then we process structured and unstructured data to find patterns. And at the end, so we come up with explanatory and predictive models. So these are like some of the social determinants of health indicator we could actually find based on the literature. And so these are different, for example, codes. So we could find through SNOMED, to LOINC, and ICD-10 in other, for example, existing ontologies. And so in the past couple of years, so we have implemented a couple of surveillance tools and dashboard. So one of them is POPHR, Population Health Record, which is analogous to EMR, electronic medical record, but it's mostly for population other than individual. And then we implemented PHL, Personal Health Library, and another tool, we call it SIEMA. It's funded by the Gates Foundation, Semantics, Interoperability, and Evolution for Malaria Analytics. And the fourth piece is SPACES. It's XAI, Explainable Artificial Intelligence Semantic Platform for Adverse Childhood Experience Surveillance. And the last one is PORVALT, or Policy Evaluation and Logical Testing, which mostly for intervention evaluation. So you can find information about these tools in the references below. So in our framework, so we use pieces from these different systems. The POPHR, as I said, it's analogous to EMR, but for population. It's a web-based semantic web tool. So people can go and there is a natural language interface. There's no need to be familiar with a specific knowledge representation tool. People can search for different, for example, condition, here diabetes, they get suggestions. They choose a concept, they click on a concept, they will find different, for example, risk factor attached and determinant attached to, for example, diabetes. So we know body mass index has something to do with diabetes, or sleep apnea, or like social economic condition. And for example, if you click on body mass index, then you're going to get the causal pathway. Shows, for example, calorie intake has something to do against smoking, and you click on calorie intake is these like software consumption, fast food density. So these are like upstream determinant linked to different concept, and this actually causal pathway generated through the knowledge that we extracted from literature. So there's no data at this point. And then we populated the data into this conceptual framework, into this causal pathway. And then based on the existing condition in, for example, our population, so we can actually highlight the link between two conditions. Here, for example, we choose diabetes, and then we find there's a strong correlation coefficient between diabetes and developing congestive heart failure. And so you can actually compute the correlation between each of these two concepts. And if it's thick red, it means it's strong positive. If it's thin red, it means it's a big positive. And if it's a dashed line, it means it's not significant correlation. And if it's blue, it means it's negative. And then you can actually geocode this in your geographical area. And then there is a time slider, so you can move it to different time point and find out how the trajectory changes through time. So we expanded this platform, and now we are implementing what we call it urban health observatory, population health, urban health population observatory, or for acronym we use UFO. And the concept is actually not totally new. So World Health Organization mentioned the term in 2014. And so they mentioned in order to coordinate effort within a city, we need a balance between the data management tier with the infrastructure exists in the city, and all of these data sources should be analyzed in an intelligent format, enable better public health decision making. So we focus mostly on the bottom tier here in knowledge and intelligence. So you see the data coming from individual and population level. There is an interoperability and data integration engine here. And using this knowledge, people are supposed to make better informed decisions. So we came up with the prototype development of this platform. So we have a data layer, we have analytics layer, and application layers at the top. So the data coming from different sources, both health sources and also non-health related sources, including social economic determinants. And at the middle, we have analytics layer. We do epidemiological and statistical inferencing, and we do geocoding, geomapping. And at the end, so we are having an application layer. It's a user-friendly, intuitive platform, and it's customizable for each type of user, whether people are coming from the healthcare, for example, provider staff, or if they are policymakers at the city level, or they are just epidemiologists or researchers looking to find, for example, correlation between different data set in the city. So that's pretty much the data and analytics layers. So at the top, we have individual level and population level. So we have geocoded information, and we perform geospatial modeling here. And also we do causal inferencing, and we can examine different epidemiological hypotheses. So it's pretty much a marked prototype of the system. And so you can pick a specific health condition here, for example, COVID, and then you have a tabbed view of the provided feature. We have causal structure. We can do regression, and we can do regression. We can do intervention evaluation, hotspot analysis, and spatial distribution. And you can pick, for example, COVID-19 testing or hospitalization, mortality, vaccinations, and then you can actually expand the causal pathway. Again, the knowledge is generated from the literature, and some of the existing data set. And then when we populate this causal pathway with the actual data set, so we can get this color-coded link between the different upstream, for example, health determinants and downstream health consequences. So this platform is still under development, and so we do some geospatial analysis capacity as well. And so we can actually overlay different conditions and find out, for example, how, let's say, poverty correlate with COVID-19 testing or lack of access to internet or different social economic status, how they play a role in COVID-19 testing or vaccination. And again, we can do time series analysis and find out whether, for example, at one specific point of time, we can make a specific decision based on, for example, the data we have. For example, if you see the number of cases are going down, vaccination are going well, so we might think of reopening the schools or businesses. And so there are a series of epidemiological hypotheses we got from domain experts. So now we're working on, some of them are addressable using the existing infrastructure. Some of them needs a little bit more data sets. So, lack of data at the appropriate level of granularity is one of the challenges we're currently dealing with. And so that's pretty much a dashboard that this dashboard is the one we use for our adverse childhood experience recommender system based on explainable AI platforms. And so we haven't implemented this for COVID yet, but we expect this to be very similar, so people can actually go to the platform into a chatbot. They can actually communicate with the system, and based on the input, where they live or where they want to travel, what are the risk factors. They can, for example, get recommendation whether to maybe it's better to stay at home based on, for example, the sign or symptom, or if they are looking for the nearest for example, testing site or vaccination site to the home address, so the system can actually come up with different recommendations. And overall, knowledge-based health analytics supports inferences about who, why, where, and when questions. And also we can use this data set to answer what and how questions. And we're a little bit more ambitious with the what and how questions, but that's what we are aiming for. And also we can simulate the consequence of, for example, a specific scenario before it actually takes place. And we can actually find hidden dependencies and generate new knowledge between different data sets that we have. And so pretty much the major problem we have right now is mostly related to the data and some of the legal and ethical challenges we have to overcome. And I should appreciate our team at COVID-19 Observational Registry team at the University of Tennessee Health Science Center. And thank you.
Thank you so much. Let me see if there are any, I don't see anything, any questions posted in the chat or Q&A. Folks, if there are any questions, you guys can raise your hand or post them in the chat or Q&A. Arash, thank you so much for a very interesting, insightful presentation.
You're very welcome. Thank you.
So if we have a few minutes, I'll just make a quick comment. Arash, that's really beautiful work. Thank you so much for sharing that with us. One of the reasons I was so excited to have you present to everyone is because, you know, as you may know, we're doing some work with implementation of different types of knowledge graphs within the enclave alongside the clinical data, and there's a lot of commonalities with your work. And so I'm hoping to connect you with some of the other community members who've been working on that and thinking about how can we actually leverage some of the expertise that you have in bringing together these clinical data with the knowledge graphs for the social determinants of health in particular, but all the other knowledge integration that you have that's been going on. So just wanted to make that comment for those in the audience that are working on the knowledge graph aspects to please reach out to me or to Arash so that we can incorporate him into our future thinking.
Sure. Thank you very much.
Comments as well.
Great. Thanks, Melissa, and thanks, Arash. So I don't see any questions. Maybe if we have questions towards the end, we'll take some questions at that point. I'm going to turn it over to Noha.